touch it and you die. It is a rare politician who has the guts to debate Canada's healthcare system unless it's behind closed doors. Globe and Mail columnist Jeffrey Simpson is an intrepid national affairs journalist who says the time has come for us to have an out-loud adult conversation about the unsustainability of public and private health care. It is the kind of political hot potato he likes to smash, which he has done in his new book, Chronic Condition. Why Canada's healthcare system, one of the most expensive in the world, needs to be dragged into the 21st century. $200 billion a year? Are we getting our money's worth? Hear what Simpson says next. It's good to be here with you today and with Jeffrey Simpson. He is one of Canada's best investigative journalists, one of the few national affairs pundits who has a degree in history and political science and a degree from the London School of Economics. He also has an Order of Canada and a resume that includes in-the-trench political experience, as well as prestigious awards for his nonfiction book writing. In his new work called Chronic Condition, he did not set out to trash Medicare, but to look at our choices and our options that will drag Canada's healthcare into the 21st century. Welcome.
Nice to be here again.
And drag is the right word.
Well, I think so because when you drag something, you kind of pull it along and it moves slowly. You're not jumping, right? A system that's as complicated as Medicare, you're not going to have some phenomenal leap forward, but you have to, on a range of fronts, kind of pull it. And I have some new ideas in there, I think, but I've got a lot of ideas that have been around for quite a while. And the question is, can we get the political urgency that's necessary to drag the system forward? Because the bottom line, the takeaway line, is that if you compare us with other largely public systems, forget the U.S. system. It's a private system. It's used as a bogeyman to scare Canadians. We're in the top 5 when it comes to the amount of money we spend, which is okay. I mean, we're a rich country. We can spend whatever we want on healthcare. But when you look at the international studies of how good our system is, however you measure it, we kind of come in the middle at best. So there's a problem here. That's why I say we've got a Cadillac from a cost point of view, but we don't have Cadillac for results. We have a Chevy. And nothing wrong with Chevrolets. I mean, Chevrolets can go a long time, but you wouldn't pay Cadillac costs for them, would you? No,
I wouldn't. So take me back to the beginnings, because you do that in Chronic Condition. The champion of this system, Tommy Douglas, yes?
You know, the irony, because I'm here in British Columbia, and I'm going to talk about this, I've got the privilege of speaking at the Vancouver Institute on Sunday night, when I talk for a long time. Actually, the first discussions about whether we should have something called a public healthcare system were in British Columbia after the First World War. They went on for 6 or 7 years. They eventually petered out, but this was the place where the first discussion, and it was animated by soldiers who'd come back from the First World War, where they had had better medical treatment than they got when they got back here. And so there was something called the Soldiers' Party in British Columbia that began to say, hey, we need, anyway. Yeah, Tommy Douglas started it, and the basic deal there, which is still at the heart of our system today, is the state will cover hospitals and doctors, period, okay? There was a hope in those days that it would be extended to other things, eyeglasses, dentistry for kids, drugs, and we still are locked a bit in that system. You know, when we started Medicare nationally, 1972 was the last piece that dropped in Yukon, the average age of the population was 27. Now the average age of the population is 47. And that requires a different kind of system.
The gray tsunami.
Well, no,
the
it isn't.
Boomers
No,
are
no,
aging,
you know,
or whom?
I'm going to bite you on that. Because,
okay, good.
Because a tsunami suggests, bang, it all arrives in a rush. That's not what aging does. Aging is incremental. Aging each year produces more people who are old, which incrementally puts more costs and pressure on the system. There is no gray tsunami, and we're going to have more costs, to be sure, because the population's older, but we can handle it if we do the right things.
So you're saying, in essence, and you said in here, it's not a budget breaker.
No, aging's not a budget breaker. No, it's going to add some additional costs. The best estimates you can find are that it will add about 1 or 1.5% to the total health care cost. The principal reason why we need to have a conversation now is for 3 or 4 reasons, one of which is aging. The second of which is that when the premiers got together, Paul Martin and the premiers, they decided back in 2004 to put $41 billion into the system, indexed at 6% a year. I bet you and I'd love to have our salaries indexed at 6%.
Would, definitely.
Well, Mr. Harper's announced that in 3 years, that's going to go to 4%. So there will be less money from Ottawa, the provinces. That'll pinch. We also know that after the recession, we can see it now, for about a decade, there's going to be slower economic growth than there was before. So there'll be less revenue increases for governments. So you put all these things together, the pressure from healthcare spending on the total amount of money that governments have is going to increase. I mean, here in British Columbia, it takes 42% of the total amount of money that governments spend. In some other provinces, it's 45, 46%.
Sure. Some provinces are rich, some provinces are not rich. Alberta, Ontario, example.
Well, Alberta's probably the province that can keep spending on healthcare going at 6 and 7%, and they've got enough revenue coming in from the oil sands and elsewhere to pay for it. But other provinces aren't so lucky. So if you look, and I actually know the numbers for BC, what's happened in BC since the early part of like around 2000 is that every budget, the government stuffs more money into healthcare, and the government puts some more money into education, and then everything else gets flatlined or is reduced. Now you could say, well, the answer to that is to raise taxes. Okay, well, let's have a discussion about that.
Exactly, but most Canadians would say, we want more of it, but we don't want to pay more tax.
And so the answer that the public gives when you say, look, you want more, but you want to pay more for it? They say, make the system more efficient. Get rid of waste and duplication, which is a very good idea. But the notion that by making the system more efficient, you're going to be able to solve this funding problem is, I don't think, correct.
When you talk to Dr. Turnbull, former head of the Canadian Medical Association, he takes you into the hospital in Ottawa.
Yeah.
You talk to some of the patients. First, I think they ask you if you were afraid of blood.
Well, when I went into the operating room.
And there was a good example in the book. Older man had a urinary tract infection, not life-threatening,
Yeah,
but
he's
in the
very
hospital.
elderly and very frail.
Elderly, very frail.
So I said, okay, I've been dealing with this at a high level of abstraction. I should actually go see what's going on. So I spent a week at the Ottawa Hospital, but it's a template for big hospitals in all cities across the country, Vancouver, Calgary.
Teaching hospital?
Yeah, teaching hospital. Two takeaways. One, I was so impressed by the skill and the dedication of the people that I saw working there. I mean, to go into a surgical room and see a physician helping a young girl who had cancer get the tumor out, I mean, and watching Jeff, I mean, it was very impressive. On the other hand, I stepped back and I said, you know, this hospital is being asked to do things that in a properly organized system, it would never be asked to do, to wit. 13% of the beds, and this is true in all the big hospitals, are taken up by frail elderly people who shouldn't be there. They cost a huge amount per bed. They should be in nursing homes, home care, long-term care. You saw the big people, the big lineup at the emergency, and you'd go around and you'd talk to people and you'd watch them be processed, and you said, you know, a lot of these people shouldn't be here. They should be at a family clinic somewhere. Well, why aren't they? Well, they can't find a family doctor, or because the family clinic closes at 6 o'clock, or whatever.
Or the family doctor says to them on the side, I can't get you that test for 3 months. But if you go to the hospital, you'll get it. You'll get it right away.
And in fairness, they try not to do that, but I mean, give them the test. But no, that's right. And then the third thing that hits you, and the Ottawa Hospital has a nice round number, so it's easy to understand. There are 100 operating rooms. 4 of them stay open 24/7 for emergency purposes. Fine. The other 96 open at 8 and close at 4. 5 days a week.
Not even banker's hours.
Walmart's open from 7 in the morning till 10 at night, and they're closed on Saturday and Sunday. So 96 of the 100 ORs are only open 8 hours a day. So the total number of OR times, available times, is only used about 30%.
Why?
Because the hospital gets a global budget from the province, and they have to squeeze the global budget into the number of patients that they can take. Until recently, and British Columbia is on the cusp of this, and Ontario, where they're changing the formula so that the hospitals are rewarded for the number of patients they put through. You put more through, you get more money. But prior to that, there was no incentive. But you know, if you took that situation to a first-year commerce class and say, okay, large unmet demand over here, witness to which are wait times, large unmet supply over here, witness to which are vacant ORs 70% of the time, please fix. That'd be the easiest assignment they had all year. They'd use a price mechanism and they'd figure out how to price the operations and get doctors and nurses and so on to work extra hours to provide more service so that more patients could go through. But that's verboten in Medicare, so we have the situation where you have all this unused capacity and you have the worst and longest wait times in the Western world.